Good evening. My name is Roxanne Chabot from RBC Consultants. Welcome to an International Dermatology Foundation Educational Series webinar. This evening, we're going to discover the science behind VTAMA. Our moderator is Dr. Danielle Butler, who is Associate Professor, Division of Dermatology and Assistant Dean of Student Affairs, Director, Inflammatory and Aging Skin Research at the University of Arizona College of Medicine in Tucson, Arizona. Our speaker this evening is Dr. Adelaide Hebert, who's Chief of Pediatric Dermatology at McGovern Medical School, UTHealth Houston, and Children's Memorial Hermann Hospital in Houston, Texas. We'd like to thank our supporter, Organon Dermatology, for making this educational event possible. Before we begin, a couple of logistic tips. If you're having issues hearing the webinar, you can listen to the presentation using your telephone. Just select Settings and the phone call in the audio pane, and the dial-in information will be displayed. If you're having technical issues, please submit your question or your technical issue in the question chat pane on the top right-hand side of your screen. At the end of the webinar, a survey will pop up in your browser and also will be sent to you 1 to 2 days later. We greatly appreciate it if you could fill it in and send it back to us. And finally, within 1 to 2 days of the webinar, a certificate of attendance will be emailed to you. So again, please submit your questions using the question pane on the top right-hand side of your screen. And now, without further ado, I will pass the floor virtually to Dr. Butler.
Thanks so much, Roxanne. It's such a pleasure to be here with you guys and getting to introduce the concept and our speakers. So next slide. So as I mentioned, or as Roxanne mentioned, I'm Daniel Butler. I'm here at the University of Arizona, but it's my pleasure to get to stand in for this wonderful team at the International Dermatology Foundation. And the International Dermatology Foundation really started as an educational initiative, and its core principal mission is to raise awareness and improve dermatologic care all over the world, especially in underserved areas through these educational initiatives. So really proud to be standing with this team. We'll see the next slide. And of course, I'd be remiss not to mention Leon there, who's a titan and someone whose educational mission is all over this. You know, we've had many previous educational sessions, anything from discussions of atopic dermatitis to HS to psoriasis. So please continue to tune in to find out the latest and greatest things happening all across the dermatology ecosystem. And then to stay in tune with all the DEF Educational Series webinars, please follow us on Instagram, LinkedIn, Facebook. You can find these educational events through those portals. So without further ado, why you all are here is to discover the science of VTAMA. So it's my absolute pleasure to introduce Dr. Hebert. She's the Chief of Pediatric Dermatology at McGovern Medical School at UT Houston. So without further ado, Dr. Hebert, please take over and let us know about the science of VTAMA.
Well, thank you, Dr. Butler. I'm really happy to share with you some exciting news related to VTAMA. Today, we're really going to look at a number of aspects, including the clinical trials, but also the action and the efficacy related to VTAMA cream. This is a relatively new medication that we have for both psoriasis and atopic dermatitis. But today I'm going to focus on atopic dermatitis, particularly in patients as young as 2 years of age. After all,
so Dr. Hebert,
yes.
We can see the slides, but we cannot see you. So if you could turn your camera on.
I forgot to turn that back on. I appreciate that. Thank you so much, Roxanne. Again, I am here.
There you go. There's lovely you.
Thank you, Roxanne. Again, we're going to talk about this unique medication, VTAMA, which is a first-in-class aryl hydrocarbon receptor agonist, and again, approved as of December of 2025 for patients with atopic dermatitis as young as 2 years of age.
And you can just, click, there you go. Oh, click in the middle of the screen and you should be good to go. There you
Okay.
go.
All right. As you may be aware, I am speaking on behalf of Organon, and I am being compensated by Organon for this lecture this evening. I do need to stay on topic. I can't discuss off-label indications and so forth. I am being compensated by Organon for this educational opportunity this evening. We're going to start off at first looking at and discussing the complex impact of atopic dermatitis. This is really not just a skin disease. This is an entity that affects the immune system, but it also affects the child or the adult patient, and it affects the whole family. And that's true whether it is an adult or a child that is receiving care from you as you work every day in your clinic or hospital. So let's go on and take a look at the commonalities that we know about the incidence and clinical features of atopic dermatitis. It's remarkable that over 26 million people in the United States have this disorder. Of those, 9.6 million are actually under 18 years of age. I have to say that atopic dermatitis is something that I see absolutely every single day in my clinic. And we know worldwide the incidence of atopic dermatitis is increasing. We believe in the United States we may be seeing more atopic dermatitis than ever before because we're seeing more immigrants come to the United States. And whether one parent or both parents were born in a different country, those children of those parents do have a higher risk of developing atopic dermatitis. So keep that in mind. All right. There are a number of common signs and symptoms of atopic dermatitis. Those of us in dermatology recognize that this is truly a clinical diagnosis. It's not one for which we typically need a biopsy or blood test or other studies to absolutely be certain we have the right diagnosis in hand. Almost every patient who has atopic dermatitis will, by definition, suffer from pruritus. And this pruritus can be one of the most problematic arenas of the disease that we need to work so hard to control and improve upon so the patient can not only rest, but their skin can heal. We also know that xerosis or dry skin is such a common component of this diagnosis as well. And just about every patient, regardless of where they live or how they take care of their skin, will suffer from time to time the dryness. And this dryness is important because if you look at the guidelines for care across really the world, moisturization of the skin is really one of the standards of care, regardless whether you're in the United States, Canada, the Far East, Europe, and so forth. So keep this in mind as a cardinal feature that we see with atopic patients. We also know that we can see stage-specific features in atopic dermatitis. We can certainly see acute atopic dermatitis, and the acute flares are often what drives these patients in to see us in the clinical arena. We can see eczematous lesions that are more subacute, and of course, we can see many patients that have the chronic features that are depicted here. I ask that you look carefully at those sort of scratches that are linear. And this is a feature of atopic dermatitis because the alteration of actually the way the cells adhere to each other that we see so classically in atopic dermatitis, but yet we don't really see these type of excoriations as much in psoriasis or lichen planus, even scabies. So we know that these are features that lead us to the right diagnosis if we look carefully and think about what sits in front of us in clinic that we are going to talk about. Let's look at the variety of skin types. We know from previous clinical studies that we haven't had the true mix of patients across ethnicities that really reflect what we see in the United States. Fortunately, that's changing, and I will say there has been a big push by the FDA as well as our colleagues in pharma to ensure that we have a very diverse enrollment, regardless of what geographic area we come from or participating in a clinical trial in terms of a principal investigator. Let's go over these skin types and some of the findings that we see. You can see on the far left, Fitzpatrick skin type 2 with marked atopic dermatitis impacting the palm and the wrist. We see the dorsal hand in a higher Fitzpatrick skin type in the second portion of this slide depiction. And we see the skin types 6 both with the foot, with lichen simplex chronicus, and the antecubital fossa being affected. Keep in mind when we see this degree of lichenification, it is suggested from a much older article in the Journal of Investigative Dermatology that one must actually rub or scratch about 140,000 times to actually manifest this lichen simplex chronicus. So lots of itching, lots of rubbing, lots of scratching going on for these poor patients suffering with their atopic dermatitis. So we're going to look at the impact of atopic dermatitis. We need to recognize that this is a truly systemic disease, and it is for this reason we often have to manage these patients accordingly. We know that there are impacts due to atopic dermatitis upon the family, but also on the physical and mental well-being of those within that family unit. So when we take these considerations into the way that we're going to arrange to treat this patient, we need to think about the physical changes, which encompass not only the itch, but also the red, often raw, irritated skin, the scratching that occurs, and as I mentioned, those open sores, which are often quite linear and profound in atopic dermatitis. When we go on to think about some of the other issues that can occur, we know that there can be epidemiologic findings, there could be psychiatric and anxiety components that go along with atopic dermatitis, and even depression. We have to respect these findings, address them accordingly, or at least get them to the proper physician who can assist us with that management of their disease state. Sleep disturbance. Well, I can tell you as a pediatric dermatologist, that's one of the most common complaints I hear from the patients for whom I provide care, or at least their parents tell me they're not sleeping. And this results in poor performance in school, the children don't behave well, and it's a disruption for the entire family unit. If a child is not sleeping, the parents also are not sleeping. So again, the impact on the family could be quite severe. Up to 47 to 80% of patients in the pediatric realm can report sleep disturbance, and it can be as high as 87% in adults with atopic dermatitis. So keep that in mind. I do myself ask about sleep disturbance because we know with lack of sleep, children don't secrete the growth hormone that they need to have linear growth, and they can actually fall off their growth curves. And that, of course, is a well-known phenomenon in atopic dermatitis at this time. The family impact I've talked about, this can be both a financial burden, the number of prescriptions that have to be written, and the amount of time that is required to actually provide adequate care for the skin of a child or family member who suffers with atopic dermatitis. It can be quite impactful within this family unit. All right, let's go on and look at the atopic dermatitis complexity, which is, of course, multifactorial. We know that we have two key things that we need to address as we design a therapeutic intervention for atopic dermatitis. First and foremost, we have an abnormal skin barrier. This skin barrier malfunction, if you will, really is what allows the loss of water, leading to the dryness in the skin, but also it increases the risk of the patient developing infections, which can be viral, fungal, or bacterial. We know that immune dysregulation also is very problematic in these patients. We recognize the heightened immune cell responses and that these patients indeed have increased levels of inflammatory cytokines. This is a result of the disease-specific T helper pathways, more likely to be Th2 than any other pathways that we see in other inflammatory dermatoses, such as psoriasis, which is more likely to be Th1 mediated. The skin barrier dysfunction creates one of the biggest problems and challenges that we face because even when the skin looks normal, it is not normal. And that's one thing we have to keep reminding our patients and parents because they have to use moisturization even when the skin looks and appears normal. Why is the skin barrier abnormal? Well, we have a reduction in skin barrier proteins, and these include both filaggrin and other components. We know this vulnerability in the skin makes it more susceptible to irritants as well as allergens. And unfortunately, these irritants and allergens actually go on to further promote the immune response, which is unfavorable. Okay, let's look next at the real core of what we're going to discuss today, which is VTAMA. And VTAMA, also known as tapinarof cream 1%, is defined as an aryl hydrocarbon receptor agonist. And currently we have the indication from the FDA that it is used as a topical treatment of atopic dermatitis in adults and children at least 2 years of age and older. What are some of the safety concerns that I need to address with you this evening? Well, we know the most common adverse reactions seen in the clinical trials included upper respiratory tract infections. That's very common in many clinical trials, whether in dermatology or in other disciplines. Folliculitis, and I'll talk a little bit more about that specifically in slides that follow. Lower respiratory tract infections, headaches, asthma, vomiting, ear infections, pain in the extremity, and abdominal pain. Now, it doesn't mean that all of these specific findings were exactly the cause of using VTAMA to treat their atopic dermatitis, but this is what the patients reported, and this is what we must record as we conduct clinical trials. Keep in mind, as we're treating patients in the pediatric group, many pediatric patients who don't even have atopic dermatitis and don't undergo VTAMA therapy can also have many of these findings as well, including the infections of the respiratory tract, abdominal pain, vomiting, and ear infections. So, why does an aryl hydrocarbon receptor actually lead to normalization of the skin barrier? This is an important construct that I want to discuss with you. One of the things that this aryl hydrocarbon receptor agonist does is help balance the immune response by actually reducing pro-inflammatory cytokines. That is a really important role for any topical agent that we would consider in the treatment armamentarium of atopic dermatitis. We also want to restore the skin barrier because I spoke before about the dysfunctional component within the skin barrier, which makes it more transparent, if you will, to allergens and triggers. So if we can upregulate those genes that encode the skin barrier proteins, which include filaggrin and genes that involve ceramide production, we're going to have a better barrier in the long run. We know that the aryl hydrocarbon receptor itself is actually highly expressed in epithelial and immune cells of the barrier tissues, and that includes the skin, the GI tract, as well as the lungs. So this is a fairly universally found receptor throughout the human body. All right, where does tapinarof come from? Let me go back. Well, it has a very interesting story. And what we see is that it actually came from, I'm trying to go back. Here we go. Here is the interesting story. Well, it keeps going back twice. I apologize. It has a very interesting story. I think it'll go forward again. We'll get it to go back.
Did you want me to try to make it go
Yes.
back,
Yes.
Dr. Hebert?
Yes. Actually, I want to go forward now. I'm just not getting it to work. Let me see if I.
There you go.
Okay. All right. Let me go back again. I'm so sorry. This is a rather sensitive trigger here. I do want to talk about the worm story. We just can't miss out on that. Okay, here we go. So tapinarof really is a naturally derived aryl hydrocarbon receptor ligand, and it was first discovered in nematodes that infected moth larvae, and the moth larvae didn't actually break down. So you can see the nematode depicted on the far left. The actual bacteria that it carries is P. luminescens, and this P. luminescens is in the intestine of the nematode. And here you see what that looks like as an organic compound, tapinarof. And so this is a really interesting compound that was found I don't know who has this original interest in nematodes, but we are very fortunate that they did, because we have now a medication to treat both atopic dermatitis and psoriasis as a result. But indeed, this is a truly naturally derived product. We don't make it from nematodes. It is synthesized in the lab now, but an amazing discovery, which really led to a remarkable drug.
Just give it like 1 or 2 seconds when it switches.
Okay.
There you go.
All right, so let's talk about the pathways involved in atopic dermatitis that actually lead to the activation of tapinarof. And you can see here, look at that little purple segment within the nucleus. It goes in and attaches to the appropriate receptor, and by doing so, it impacts gene expression. And this is really magnificent because indeed, if we can upregulate both filaggrin and ceramides, we are going to have skin barrier restoration. We also indeed benefit, or our patients benefit, in terms of the anti-inflammatory effect, because there is a reduction of those inflammatory cytokines that lead to the dryness, redness, and itching in the skin of atopic dermatitis. All right. I mentioned the dual anti-inflammatory action and the potential barrier restoration. These are really key features that we believe that tapinarof brings to the table as we manage patients with this skin disorder. I really apologize that I'm having trouble getting this to move forward, but okay. So let's look at the clinical trials. And I was very fortunate to be one of the principal investigators in this study. And I have to say it was very impactful for the patients for whom I provided care. And many of these patients remain on this medication to this day. The clinical trials were called Adoring 1 and Adoring 2. This was a phase 3 pivotal study, and it was 8 weeks in duration. We were able to enroll patients that were at least 2 years of age. They had to have what's called a validated IGA in atopic dermatitis with a score of at least 3. They had to have an EASI score of 6 or greater, and they had to have a body surface area ranging from 5 to 35%. Now, even though in the clinical trial we had the limitation of 35% as part of the clinical trial criteria for enrollment, we have no limitation in the use of this product in terms of body surface area that you would once you prescribe it. So keep that in mind. We did enroll a very diverse study population. We had patients ranging from 2 to 81 years of age, and we had 80% of those patients who we did enroll in the pediatric realm. So that made me extremely happy as a pediatric dermatologist. And 50% of the patients were skin of color patients by their own self-definition. So this was wonderful. Now, why do we have two different studies? Why do we have Adoring 1 and Adoring 2? Well, those of you who don't do clinical trials perhaps need to have a little bit of explanation as to why this happens in most clinical trials conducted in the United States. The Food and Drug Administration wants to make sure that our science is reproducible. So one must have 3 clinical trialists in 3 geographic areas in the first trial, and in the second trial, 3 different clinical trialists in 3 different geographic areas. So we're really getting the diversity of the United States when we conduct these trials. And again, this was a double-blind study over 8 weeks. We enrolled just over 400 patients in each of the arms of this study. We wanted to see what the primary endpoint, how many of our patients could meet the primary endpoint, which was construed as patients who had a validated IGA getting to clear or almost clear and a grade 2 or more improvement from baseline at week 8. So those were our primary endpoints. We had secondary endpoints looking at their EC75 at week 8, comparing that to baseline, and achievement of a greater than or equal to 4-point improvement in their weekly numeric rating score, which is their itch score. And we compared that in patients over the 8-week time course. Now, because of the validation of this particular criteria, the numeric rating score, we wanted to look at patients greater than or equal to 12 years of age because we really don't have validation into the younger age groups for that particular scoring modality. So just to explain that, we also, of course, always have to record safety and tolerability. If there were any adverse events or serious adverse events, we are required as trialists to record these. Even if a patient stubs their toe, that gets recorded. If they break their leg, that gets recorded. So all the adverse events that I'll cover with you in slides to come will touch on this. We also look at some of the other peak pruritus numeric rating score endpoints. We looked at quality of life issues, and we looked at POEM. And I just want to remind you that POEM really looks at itch, reported itch, sleep disturbance, if your skin is cracked or flaky or dry or rough, if you have bleeding, weeping, or oozing. So that's more of a subjective type of commentary that we record for these patients over the course of the study. All right, so in the pivotal studies, what we really want to share with you today is the exciting news that in an 8-week study, 48% of those patients who had atopic dermatitis really were able to get to clear or almost clear. And this was true monotherapy. They could not even use a moisturizer on the areas with the atopic dermatitis that were treated with VTAMA. So that is something to keep in mind. I'm not recommending that as you go forward and care for your own patients, that you limit moisturization in concert with VTAMA, but as part of the clinical trials, this was true monotherapy. So let's look at trial A and trial B depicted here in front of you. As you can see, over 45% of the patients achieved this key endpoint in Adoring 1, and 46.4% achieved this key endpoint in Adoring 2. So this is really nice. They got the validated IGA success and at least a score of 0 to 1 in terms of overall IGA when they at the end of the study. Again, 8 weeks. All right, another really important way to look at the IGA response and differentiating the active arm of the study, those people on VTAMA depicted in pink, from those patients, the unfortunate ones who were randomized to the vehicle, you can see that we had over 8 weeks a 3-fold greater improvement with statistical significance when we looked at the IGA response. 45.9% of those randomized to VTAMA compared to only 15.9% of those who received the vehicle. You may wonder, why is the vehicle arm doing this well? Well, there's a lot of reasons for that, and I want to go over some of those with you now. First and foremost, we always want an excellent vehicle when we're treating any patient with a skin disease, particularly atopic dermatitis, where we have an inflamed and defective barrier. In addition, we provide the medicine for the patient, so they actually get the medicine and they don't have to go to the pharmacy and pick it up or wait for it to come in the mail. We spend a lot of time with these patients educating them on how to use the medicine correctly. We also want them to report any infections or adverse events promptly. We get them back into clinic as quickly as we can. So any adverse event or any other concern that the patient might have, we can address it very promptly, take care of it, and these patients tend to do very well. But notice that the differentiation starts very early. Even as early as day 1, we start to see a break in the vehicle-controlled arm of the study compared to the VTAMA arm. So again, very prompt response and also sustained response over the course of the 8 weeks of this clinical trial. And that's indeed what I certainly saw with the patients I treated with VTAMA during this clinical trial period. So I'm very happy to share this information with you. All right, we're going to look next at different age groups. And this is really important to understand because what we can see is that those patients 2 to 8 years of age did remarkably well in Adoring 1. And I'm trying to bring up Adoring 2. I'm going to keep clicking till I can show it to you. Just give me a little second here. Notice that the 2 to 6-year-old group did exceedingly well, and the 7 to 11-year-old group did well also. And compared to the gray bars where you see what happened to the group on the vehicle cream, and also those patients 12 to 17 years of age did well. I think across the board, each of these cohorts randomized to VTAMA superseded the outcomes that we were able to achieve with those patients who received only vehicle. And that just is a testament to the efficacy of the VTAMA used in this clinical trial. And this was once daily application. And keep in mind, this was true monotherapy. The patients did not receive moisturization on those areas treated with VTAMA. So very exciting data to share with you. Sometimes I get asked, why do the patients, the youngest cohort, seem to do so well? Well, we know that if you're only 2 to 8 years old, you're probably not putting the medicine on yourself. You have a parent who's overseeing that application. And these are parents who agreed to be in the clinical trial, accompany their children to the visits. And so we probably get very good compliance with this particular regimen. But again, it's a testament to this medicine that across all the age groups, we certainly had a superior response when VTAMA was used compared to the vehicle cream alone. All right. The next slide, we're going to look at the clinically meaningful itch response. I'm going to try to go back. And certainly what we saw with that clinical itch response was a very nice reduction in itch over time. And here we depicted, again, VTAMA in pink and the vehicle in the gray. We had in Adoring 1.5 times greater response in clinically meaningful itch relief if you were randomized to VTAMA compared to those patients who received vehicle. Now, those in the Adoring 2 did nearly as well, with 52.8% in the VTAMA arm compared to only 24% of those on the vehicle arm. So a remarkable response overall and very successful control of itch. And again, this is monotherapy, once daily application over an 8-week time course. So keep those parameters in mind. We're going to go on also to look at how rapid was this itch relief detected. And I'm happy to share with you, it was as early as day 2 that there actually was a statistically significant improvement compared to baseline in those patients who did receive VTAMA. Now here, instead of looking at weeks, we're looking at days. So this is over a 2-week time frame. And you can see that those patients who were randomized to VTAMA absolutely outperformed those randomized to vehicle cream in terms of their itch control. And again, not only was the itch control sustained over time, but it improved over the 14-day course where we've recorded that data for you in this particular slide. We did continue to achieve these benchmarks over the full 8 weeks, but we wanted to share with you the impact in the earliest moments of this clinical trial. Again, over 14 days, remarkable sustained release of itch when those patients were randomized to VTAMA. All right, so let's look at 2 pooled post hoc results, looking also at how many patients really got to a very low itch score, that is less than or equal to 1. And I'll try to bring this up for us so I can show you. So again, looking at Adoring 1 and Adoring 2, oops, went too far. Let me go back if I can. All right, here we are. So again, looking at the peak pruritus numeric rating score on your left, you can see once again how the separation occurred. And again, this is over weeks, not over days, but it was not only profound, but it was sustained, and there was not a loss of the itch control over the 8-week trial. We see that the patients enrolled to the arm where they receive VTAMA absolutely achieve by a twofold margin what the patients were able to achieve if they received only the vehicle cream. And we look at those patients on the right-hand portion of this slide who got a score less than or equal to 1. That is minimal to no itch. And you can see that again, the VTAMA arm outperformed the vehicle arm twofold. So again, remarkable results, sustained itch relief, monotherapy over an 8-week time course. Okay, so looking at EZ75, and we think about EASY scores because it really does tell us quite a bit about the eczema in its totality. And if we look at comparisons in terms of baseline to week 8, we can see that both Adoring 1 and Adoring 2 had fairly similar outcomes, again with twofold to threefold improvement compared to those patients randomized to the vehicle arm of the study alone. So very exciting data to share with you. Again, a single cream monotherapy, really great data that we were able to achieve. And I was just so pleased to see my patients respond so favorably to this cream. And the parents were very happy as well in the response that they saw in their child. So I want to go over some post hoc results, the EASY 150, the EASY 50, 75, and 90 responses. And these are pooled post hoc analysis that I want to share with you. So the EASY 50 response is quite good. 77.8% achieved that level of improvement over the 8-week time course. Now, if we look at EASY 75, again, a bit more stringent criteria, we get to 57.4 if you're localized within the VTAMA arm of the study, compared to only 22.1% in the arm receiving the cream alone. Now, as we go on to EASY 90, we can detect that, again, 30% of those patients over 8 weeks really had almost complete control of their atopic dermatitis, whereas only 8% of those on the vehicle alone could claim that that was what their outcome was at the end of this monotherapy 8-week study. Okay, next we're going to go on to another subgroup analysis. We want to look at the different age groups in terms of EASY 75, and I'll share that with you. All right, so I'm going to open up Adoring 1 and Adoring 2 so we can look at these side by side. And what you can see is, again, very similar results. And we see that EASY 75 very strong, particularly in our 2 to 6-year-old group. And again, I personally believe that's because the parents are taking control of it. Most 2 to 6-year-old patients are not assigned to apply their own topical medicine. But you can see that the 7 to 11-year-old and the 12 to 17-year-old cohorts also did very well in both the Adoring 1 and the Adoring 2 studies. So very nice EASY 75 outcomes. Again, regardless of age group, this medication is working very effectively. Let's go on to the next slide. All right, what about skin tones? Did it make any difference whether the patients were a light Fitzpatrick skin type or a darker Fitzpatrick skin type? Let me share with you some of the findings here. And I do apologize that it's just slow to build.
Would you like me to move your slides, Dr. Hebert?
Yes, why don't you try, Roxanne, so I can just talk? That would help me.
Okay.
All right, so here we can see on your far left a younger child with a baseline in the antecubital fossa. Notice the excoriations. I've talked about these linear excoriations being very unique in atopic dermatitis. You see a 7-year-old male with a higher Fitzpatrick skin type. Don't worry that you can't see the lichenification. We'll show that in some future slides. And a 54-year-old male looking at the hands with really significant hand eczema. I do want to mention about hand eczema one thing. You may or may not be aware, but hand eczema, hand dermatitis, not just atopic dermatitis, but hand dermatitis in general, is the #1 reason, according to the U.S. Department of Labor, that people lose days from work. So getting our workforce to be optimized, we need to have drugs that allow us to treat these patients effectively. So keep that in mind when you see this. You're not just treating the patient, you're not just treating the hand, you're actually enabling the workforce to do the work that they're set out to do in that day as they get in their car and they drive off and go to the workplace. Next slide. All right. So let's look at some of the outcomes in these patients. And I think these are very telling arenas that we can share with you. You can see, go ahead and build the whole slide, Roxanne. Here you see the patient with the antecubital fossa on your far left by week 2. Gosh, the excoriations are already begun to resolve by week 4. There's just a little bit of post-inflammatory pigmentation. This child went from a validated IGA score of 3 all the way down to a 2 at week 2, then stayed at a week from week 4 to week 8 at a 1. I look also at the poem. This is the subject. Remember, this is the itching, the sleeping, and all the things. Start off with a score of 26, wound up with a score of 1 as early as week 4, and maintain that through week 8. Another component I like to share is the itch score. This patient started off with an itch of 10, went all the way down to an itch of 1 by the end of 8 weeks. It's little wonder this skin could really heal because the patient wasn't scratching. Remember, this patient is age 9. These patients don't tend to have enormous self-control, so you can't just tell them not to scratch. That skin is very pretty at the start of the study. By the end of the study, that itch is much better controlled. Let's go on to another example. Next slide. All right, we're going to look at this patient's foot. And as I promised, you would be able to see this lichenification in a more satisfactory manner once you get to these slides. Here, this patient has marked lichenification and discoloration of the skin itself. And you can tell that this patient has an IGA of 3 at the initiation of study. While it took a little longer for this patient to improve compared to the other patient that we saw in the previous slide set, you can see that by week 8, this patient went from an IGA of 3 all the way to an IGA of 1. The EASY score started off at an 8.2, went down to a 1.1. This patient's POEM of 20 was reduced to a 0 by week 8, and the itch score, starting off at a 7, as early as week 2, went to a 2.3, and then was down to a 0 by the end of week 8. So again, remarkable results. Now you may think at the week 8, is that still some eczema that remains? We really feel that this is mostly post-inflammatory hyperpigmentation that is a residual of the chronic inflammation in the skin, and we know that our higher Fitzpatrick skin types can manifest this. Let's go on to the next slide. All right, this next slide is a patient who indeed is age 54, has hand dermatitis. You can imagine how difficult it is for this patient to go to work every day if his hands look like this, itch like crazy, and have this disrupted red skin barrier. So this patient started off with a validated IGA of 4, and by week 8 went down to a 2, a very remarkable result considering that he achieved that already by the 2nd week. Look how much better he is at week 2. I can guarantee you this patient's happiness factor, something we don't measure, is really going to be remarkable. His POEM score started off at a 28. He was all the way down to a 13 by week 8. And his itch score started off at a 5, went all the way down to a 1.4 by the end of the study at week 8. So a very, very nice display of both the physical findings, also some of the subjective findings, and the measurements that we include as part of our clinical trial to bring this patient forward to the success that we see as he moved from baseline week 2, week 4, and week 8. Next slide. All right, let's look next at some of the adverse events. Let me touch on one thing on that last patient. I'm not going to go back on the slide, but that patient was actually, that hand patient was actually considered a treatment failure because it didn't achieve the primary endpoint. But again, although he's a clinical failure, I mean, a failure based on the primary endpoints, he really did improve quite a bit. But I did want to make the point that he was not considered a treatment success within the parameters of the clinical trial. Let's look at the adverse reactions. One of the most common adverse reactions we see in patients in clinical trials is upper respiratory tract infections. And we did see this indeed in the patients enrolled in both the VTAMA arm and the vehicle arm. Folliculitis. I do want to spend a little bit of time on this. Sometimes it's called folliculitis, and in some portions of our subsequent understanding of this, we called it follicular events. We think that this is not folliculitis like you might see with pustules and so forth, and we don't necessarily feel that this is due to bacteria colonizing the skin and invading the hair follicle itself, but that we did see little hyperkeratotic papules on the skin, and according to the definition that was allocated to us during the course of the study, we call this folliculitis. We also saw some lower respiratory tract infections, some headaches, and the headaches are believed to be real. We don't have a full explanation for that, but indeed some patients stopped and started again and the headaches returned, but the headaches were not problematic and patients did not tend to drop out because the headaches were very short in overall time course. Asthma, we expect this in a cohort of patients who have the IgA scores and itching scores and atopic dermatitis that often is accompanied by asthma. Vomiting, remember we're looking at a lot of pediatric patients for this, ear infections, pain in extremity, and abdominal pain. So these were some of the more common adverse events occurring in greater than or equal to 1% of those patients enrolled on this pivotal trial during 1 and 2. Let's go on to the next slide. All right. When we conduct a clinical trial in the modern age, almost all medicines based on the FDA mandates, we have to do what's called an open label long-term extension study. And so it goes out to a year. So given that this was an 8-week study, we continued out for another 48 weeks to get the completion of the Adoring 3, the long-term extension study. So here we had a little bit of a different parameter, and I want to bring home a very important point. When we enrolled the patients in Adoring 1 and Adoring 2, we enrolled patients with moderate to severe atopic dermatitis. But here we had some direct enrollers that were also mild in their severity. And that allows us to have the FDA indication of mild, moderate, and severe atopic dermatitis for VTAMA once daily. This is a great advantage because we have a single strength agent that can be used as monotherapy to treat atopic dermatitis regardless of severity. In this long-term extension study, we did enroll patients who already had achieved clearance. And if those patients still maintained their clearance during the course of the study, we took their sample tube back. They could not treat without having the tube available to them. And then if the patients got to a validated IG of 2 or greater, we returned the tube or supplied the tube to them, and they went back to applying their VTAMA cream 1% once daily. So these patients really were somewhat what we do in real life. They could go on and off treatment as indicated by their IgA score. Now, again, we controlled their receiving the medication. So we had to wait until they achieved a higher amount of atopic dermatitis to come back to clinic. We did an assessment and then treated them or didn't treat them according to the protocol. So again, if they had a validated IgA score of 2 or greater, we provided the medication again. They went back on medicine and we recorded all of this. So at the end of study, we did take away the medicine ultimately, and we had the patients follow up in 1 week to see what would happen during that particular interval with all patients off VTAMA. Let's go on to the next slide. All right. So looking at the long-term extension study, we did not see any additional safety signals. And this study was specifically designed to look at the time off treatment. We don't usually have studies that look at this. We look at a time on treatment, but this was a unique proposal. And I'm glad that it went forward when it did because it gave us some remarkable information. So again, when the patients got down to a score of their validated IGA of 0, the treatment was discontinued. And then if they went up to the score of 2, we gave them some additional medication and they went to once daily treatment. So let's go on and look at the next slide. Okay. And go ahead and click yes. All right. So what happened during this on-off period? How did the patients do overall? Well, we did have 728 patients who rolled on to the long-term extension. Remember, we did include mild patients during this portion of the study. And we had 82% of the patients who really got to an IGA of either 0 or 1, and that's a validated IGE at least once during the 48-week open label long-term extension study. Very exciting news to share with you to get that many patients to achieve that level of success with a single agent applied once daily. Now, looking at complete disease clearance, a little bit different criteria where the patient entered with or achieved an IGA of 0. 52% of those patients on this long-term extension study actually did achieve that component of clearance. That's really a remarkable finding and one of the first studies that actually gave us that insight into the ability of this drug to achieve that level of success. So what happened during this 48-week time course for many of the patients? We actually had, on average, patients who could achieve about a 2.5 consecutive month treatment-free period. So they put their VTAMA aside, they didn't use it, they not only took it aside, we took it back so we could document this with accuracy. It wasn't just what they were telling us, it was what we actually noticed and we were able to document during the course of the study. So I want to go over that component with you once again. Many of the patients were able to achieve up to 2.5 consecutive months, not weeks, but months, where they had a treatment-free interval and didn't need their VTAMA because their atopic dermatitis remained under control. Let's go on to the next slide. All right, so let's look at the adverse events in the long-term extension study. Contact dermatitis was seen in a few patients. Here we are using the term follicular event, and we did see that in patients, and some headaches. But again, there weren't any new safety signals, and we really didn't have any concerns that we learned in this extension of the overall study that we completed with Adoring 1 and 2. And again, nasopharyngitis was most commonly reported. That's a runny nose, a scratchy throat, having a cold. All of that is lumped in a documentation called MEDRA, a medical dictionary the FDA has us use to lump all those terms together. There were some respiratory tract infections, but we had very low trial discontinuation, as low as 2.6%. I can tell you in an atopic study that is exceedingly low. With regard to follicular events, very few patients actually discontinued because of these follicular events during this portion of the study. Let's go on to the next slide. All right, so remembering again about this first aryl hydrocarbon receptor agonist, and I want to remind you about the differences between an agonist and an antagonist. If I can just take a moment to do that. An agonist actually binds to a receptor and initiates a response. And I showed you in an earlier slide that going into the nucleus, we actually saw the reduction in inflammatory cytokines and the upregulation of certain components within the skin, such as filaggrin and ceramides. So we feel that this AHR agonism actually has a capacity to invoke this anti-inflammatory activity and help restore this defective skin barrier. So this is very helpful. And just by comparison, an antagonist also binds to a receptor, but it doesn't activate them. So here the difference is the activation by this agonist, which is its really proposed mechanism of action, although we don't really know the exact mechanism of action of VTAMA. The other thing I want to remind you is that because of the long-term extension study, which included patients in the mild category, we can treat VTAMA just the same concentration, the 1% cream, regardless of mild, moderate, or severe atopic dermatitis. In addition, we were able to have a very broad range of skin tones in terms of enrollment, and we know each skin tone had favorable responses during the course of the treatment in the clinical trial. We know that we are able to deliver sustained results without loss of response as far out as 1 year of treatment. And this is even during consecutive treatment-free months. Remember, we got up to 2.5 months of treatment-free intervals for many of the patients enrolled in the clinical trials. So we'll go on to the next slide. All right. I leave you with some key messages with regard to VTAMA. One of the things I like so much about this drug is its great simplicity, because you can use it once daily. It's only one strength. It's one formulation. We can use this on all affected skin areas. I'm often asked if it can be used on the face, and the answer is yes. Like most topical medications across dermatology, it is not indicated for oral, ophthalmic, or intravaginal use. That's an FDA segment that we put in our package insert for many topical agents across the realm of medicine if they haven't been studied in those areas or are not indicated in those areas. And we know that regardless of disease severity, as I mentioned, mild, moderate, or severe, VTAMA can lead to disease control and outcome success. We don't have any boxed warnings with regard to VTAMA. We have no precautions. We're very fortunate. We have no limitation with regard to the body surface area. So you can use this medication on an ongoing time basis and an ongoing anatomic region basis. So that is a big advantage for us in dermatology. And there is no label contraindications, and there's no drug-drug interactions that are known, recognized, or included in the package insert. And there's no to minimal systemic absorption. I can tell you that I enrolled a child who had one of the highest body surface areas, and he did very well on the study. He remains on the medication. He did not have one of the higher levels when his blood was drawn as part of the PK component of this study. So again, very little absorption. Let me make another point about that, because we are treating this in 2-year-old patients and up. And if a patient, let's say, has VTAMA applied to the hand and they put their hand in the mouth, we are not concerned about safety. We're not recommending that this be encouraged in children, but should a child or any patient put a VTAMA treated finger or any other portion of their hand into their mouth, there is no issue there in terms of safety. We don't have a concern. Again, it's not for oral use, but should they put their VTAMA treated finger in the mouth, it is not a safety concern. And I would reassure the parents of that, because otherwise you're going to get calls or portal messages asking that very question in the future. Let's go on to the next slide. All right, I'm going to talk next about starting your patients with VTAMA. Now, I need for you to look very carefully at how the VTAMA tube is depicted on the left. One of the things you or your patients will quickly learn that they need to keep the VTAMA tube in this position with cap up. They can remove the cap and then begin application. They are not to turn the tube upside down, because it's likely that too much will come out. And when they apply too much, I think they may be more likely to develop what we call follicular events. So an important take-home message, and I actually put it in the SIG on my prescription: keep the cap side of the tube up when administering VTAMA to the skin. Again, this medication is once daily. It's non-greasy. It's well tolerated. It does not have any fragrances. It doesn't have parabens. It doesn't have gluten or petroleum included as part of the ingredients within VTAMA. But keep the cap side up. That is a take-home message that you need to carry forward. Otherwise, your patients and parents will tell you that a lot came out if they turned the tube upside down. All right, how do we do this? They apply a thin film of VTAMA to the areas affected with atopic dermatitis on a daily basis. They don't need to use this as their moisturizer on unaffected skin. That's not the best use of this product, and it's not that it's dangerous on normal skin, it's just not a good use of the product itself. After application, the individual applying the medication should wash their hands unless they are treating their hands with VTAMA for their underlying atopic dermatitis. Let's go on to the next slide. All right, so as you prepare to bring your patients up to speed and give them VTAMA as their prescription of choice to treat their mild, moderate, or severe atopic dermatitis, you need to use the right code. We've listed here both the codes for atopic dermatitis as well as psoriasis. Keep in mind that for psoriasis, VTAMA is currently approved for those patients 18 years and up, but the atopic codes can be used with patients for atopic dermatitis down to 2 years of age because we do have FDA approval in that very young age group at this time. It is often helpful to include, and I tend to include this actually on my prescription itself, that the patient has tried and failed topical steroids and topical calcineurin inhibitors, if that indeed is a truthful statement. And then you can note if there are sensitive skin areas such as the face, hands, or other sensitive body areas where VTAMA can be used that are affected. And I think that can be helpful when you're trying to get insurance approval. And of course, it's sometimes best to use a specialty pharmacy. That's certainly what we do in our clinic because we find that they help us sometimes with the prior authorization and they streamline the whole effort to get the patient's medication to them in a very quick and timely manner. Many patients like the idea that the pharmacy actually mails the prescription to them. They don't have to go wait in line at their local pharmacy, and that is an advantage to many of the patients for whom we provide care. Eligibility, if the patient has commercial insurance, it may cost as little as $0, but there is a special savings card that is available, and this can be expedited often if you use one of these specialty pharmacies that help us to provide VTAMA for our patients. There are over 10,000 pharmacies in the United States that have already redeemed the My VTAMA savings card. And you can scan to learn more about the savings program for your patients for whom you think VTAMA is an excellent option. And I think that is our last slide, Roxanne. Am I correct?
It is. We
So
have
again,
time maybe for one question.
okay.
So thank you so much, Dr. Hebert. That was a force. I think we have time for one question, so I'll be very brief. Who's the right patient for VTAMA?
Well, I think it's really fortunate that any patient who suffers with mild, moderate, or severe atopic dermatitis can definitely benefit from this medication. I think many of our pediatric patients, of course, are very adverse to receiving injections. We know that only too well. So again, they represent a great population to consider this medication. I have many of my pediatric patients currently using VTAMA with, I feel, very good control and excellent outcomes. Also, the idea that these patients can achieve perhaps this treatment-free interval as long as 2.5 months. There are many concerns that patients have about ongoing use of medicine. Keeping in mind that this is once daily and steroid-free, I think that's the best arena we could ever choose for our patients, but just about any patient is a good patient for VTAMA.
Great answer. Thanks so much.
All right. Well, I want to thank everyone for their kind attention today and thank Organon for sponsoring this educational program. I hope that what you learned will be of value to you and to the patients for whom you provide care.
And thank you, Dr. Hebert, for your wonderful presentation on the science of VTAMA, also your clinical insights and pearls, and Dr. Butler for moderating this session. This session is completed. We'd also like to invite our audience for our next webinar that is going to be Thursday, April the 30th, on targeting the root cause of eczema itch, the science of XRX endolysions with Dr. Latanya Benjamin. Thanks, everybody. Have a great evening. Bye now.
Okay. Well, Roxanne, I'm sorry about